All right, so we have about 14 of us now. I think people will continue to sign in, so I'll let a couple more in. But welcome everybody. As we get going, so excited to help out our healthcare innovators today. UWM Engage, if you're not familiar, is a new program we started to support innovators, entrepreneurs at UWM. So any link to UWM, whether they're current faculty, staff, students, or past alums as well, we'd love to help you. We have some great mentors on the list. Two here today on our panel are our mentors for our team. And so we're trying to help match people up with mentors if they need help in various areas, or to even practice pitching, really things like that. We have a monthly mentor meeting where our teams can practice and get advice and feedback and networking. So that's the gist of UWM Engage. And we also are trying to put together these meetings on occasion on topics that our teams are asking for help with. And so healthcare was one that several of our teams are involved in, which spurred this interest here. And so today we put together a panel with our three esteemed panelists today who've been involved in the healthcare space. And we're going to start off with just having them give a brief introduction about themselves and their background as well as their current position. And so without further ado, I will introduce the top of my screen, Scott Bolte.
Hey. I'm sorry, I thought it was on mute when I was recording a few notes, so you were all listening to me type. Apologize for that. And also apologize for the time shift. The background may not look like it's noon, but I took that photo Friday night at Summerfest, and I think it turned out really well. So I'm going to use that as my background. So my background is a little bit varied. I started in supercomputers for a decade. When we shut down Cray Computer, moved back to the Midwest and joined Marquette Medical and GE Healthcare. Did a decade doing more traditional software, but healthcare software. But then there was a real pivot for me. My sister got cancer, and my reaction was to go back to the medical college and Marquette and get a bioinformatics degree. So complementing the software I knew with a whole lot of genetics, things like that. Did another decade with GE Healthcare, this time working on precision medicine, getting genomic data into medical records so we could do quantitative risk assessments, a variety of things like that. Left GE and started a company called Trailhead, which was aimed at helping frontline physicians incorporate genomics into routine care. Wound that down due to a lot of headwinds with the fragmented healthcare system in the US. And I can get into that later if people are interested. And now I work for a biotech startup in Boulder that does industrial scale gene editing with CRISPR. We've raised nearly $500 million. There is some magic to that. It's not anything that you can reproduce, unfortunately. Aside from all of that, I've been with the I-Corps program twice as a mentor. Then I followed through as a student. I'm one of the co-founders of Health Tech MKE and a few other things around town.
Thanks, Scott. I will pass the torch to Ilka.
Hi, I'm Ilka Panzer, and I've actually crossed paths with Scott a few times during my career. I'm an engineer by training, and I started my career in the US with GE and was on the Edison Engineering Program, which is a rotational program to develop engineering leadership talent for the company, and have been in healthcare for about 25 years overall. Initially with GE, which is where I ran into Scott and we worked together on some projects, and then with Johnson & Johnson for a period of time, then joined the Blood Center of Wisconsin, which is now Versity, and went through a number of different leadership roles in initially technical parts of the organization, but then also marketing, supply chain, IT, e-business, and eventually general management. And so I've been in senior leadership roles for quite some time now. I was responsible for the diagnostic laboratories at the Blood Center of Wisconsin, then became the Chief Innovation Officer there, and then had the opportunity to join Assurance Laboratories about 3 years ago as the CEO. And Assurance Laboratories is dedicated to drug testing and medication monitoring. And I'm particularly passionate about innovation and successful implementation of medical breakthroughs to help solve real healthcare issues. And one of the big healthcare issues that we're tackling is the opioid crisis. And that is still a very problematic area, and particularly during the pandemic, a lot of patients have not received the attention and the care that was required. And I'm sure you've heard in the media about the increasing cases that we see now in overdose death. In the last rolling 12 months, it was 96,000 individuals in the US who died from an overdose, primarily of opioids, but also mental health, behavioral health type issues are on the rise. And so there's a lot of potential for us to make a difference through the work that we do and the innovations that we can bring forward. I've also participated most recently in the I-Corps program. I see Brian Thompson here too, and that was a great experience that I would absolutely recommend to anyone who is thinking about starting a business or early on in the business. I think that's a great program to join.
Thank you. I think we have all three I-Corps people here that have participated. So I'll pass on now to Mike.
Hi, everybody. My name is Mike Oldani, and I'm a professor at the School of Pharmacy, a little bit north of Milwaukee at Concordia University. And I'm also the director of interprofessional education, which I think maybe we'll get into on our panel if there's some questions. But essentially, that means I help to develop students to work on teams when they get into the healthcare marketplace, that they understand the roles of other professions. Prior to Concordia, I've been there about 7 years. I was at Whitewater for about 10 years. I'm a medical anthropologist by training. And before I was a medical anthropologist, I worked for Pfizer Pharmaceuticals for about 10 years and kind of rose up from a drug rep to a senior hospital rep. And I'd say that was kind of my really formative experience in my life, because then I have studied the industry and sales and marketing practices and have really done a lot of research, I guess, and promotion of how doctors and pharmacists and healthcare workers need to interact with the industry in an ethical way. If you know the industry in the 90s, it was sort of, I think former reps would describe it as the wild, wild west. And there was regulation, but not a lot of oversight, I guess was a way to describe the industry. So I've really worked on gift exchange and things of that nature. I am an I-Corps alum, and I've been working on kind of a novel idea that I haven't quite brought to fruition yet, but it's allowed me to really get a sense of the process, and the kind of work Ilka and Scott is really inspiring for me. So I'm glad to be part of the panel. And perhaps I can offer kind of the kind of academic perspective on how you can use some of the tools of academia to get your ideas and products going, especially early on. So thanks for inviting me. I'm happy to be part of the team here.
Well, thank all of you. This is a great mix. And we did reach out to some of our current teams to ask if there were any particular questions that they had, but please do use the chat box. We're happy to mix that in. We want to focus on what this particular group on the call needs the most. But with that, as you start thinking, I'll get to some of the questions we had on hand prepared already. And I think, following up on what Mike just said, one thing was, how do you test ideas quickly when you're in the healthcare space with the limited funding that we have as startups? What are some helpful ideas that you have from academia, or, all three of you? How did you get things going early on?
I mean, I can just jump in real quickly and just say that even when I was at Whitewater, I met Ilya Adiv, who's part of the UWM team, and Brian. And there's so many resources available in the UW system that I think the average entrepreneur or kind of startup-minded person may not realize. And so I partnered right away. They did research for me. They really got me off the ground and got me thinking in a way that, as an academic, I really wasn't thinking about the marketplace, and I didn't have a handle on that. So I would just say, number one, there's a lot of tools at universities, and there's a lot of professors at universities that might be interested in partnerships. They have funding sources. They have students that are just eager to engage. So I guess I would just sort of set the table initially by saying, really try to find out what's going on at your public-private universities. And that can really help you because often professors need to do research and there might be some overlap that you didn't realize. And I mean, I can give an idea if people are interested. I'm happy to give an example, you know, but maybe I'll hand it off to Ilka and Scott if they have some things to add.
Sure. Yeah, I think the one thing I would start with is ask yourself a few basic questions. You know, when you have an idea, there are a few things that fundamentally you need to be very clear about in your own mind. The first question is, what problem are you really trying to solve? You know, so with this idea that you have, what's the use for that, and who would use it? You know, and so if you can build it, will they come? That's kind of one question to start with. And then the next question is, will it work? You know, can you actually make it? And then the third question is, will someone pay for it? And so I would start with those three questions. And I think Mike already talked a bit about the, you know, who would buy it. And the ICOPS program has a great way of pushing you to very quickly talk to potential customers or people that you think might become customers, and in a way that you're not leading the witness, so that you can validate whether there really is a problem that someone cares to solve. The next question, will it work? You know, you want to do a quick and dirty, as I would call it, feasibility on it. And so there are different models for that. Essentially, rapid prototyping is what it was called for a long time, where can you create a quick and easy mock-up version of what it is that you're trying to produce, so that you're not solving every detail of it yet, but you get conceptually clarity on whether it will work, and that will minimize your funding. And you can always expand upon it and make it fancier and, you know, add more feature functionality, but the basic concept, test that, and will it work? And then from a will anyone buy it and pay for it perspective, you need to early on think about who you're competing against and what the, you know, the nature of funding is that people would use in order to pay for your product or service. So is it something that private people purchase? Is it some, you know, patients, for example? Is it something that a health system will purchase? Is it something that will be used under grant funding? And depending on that, your pricing models may change. Those would be some of the thoughts that I would offer.
So no contrarian views here. I'll just reinforce a little bit more vigorously. So go out with a rough prototype. I mean, if you say, oh, it needs to be polished, it needs to be ready for demo, one, you're missing out on time. And two, the psychology of people is the more effort that's gone into it, the less likely they are to give you candid feedback. They don't want to be cruel. They don't want to be mean. You've obviously put time into this. So if you go forward with, you know, rough wireframes, if you go through with paper, you know, you want to do a mock-up of an app and just say, here, this is how it would flow. The US command and control system was replaced during the Iraq war, and the demo was literally pieces of paper at the time. So just get out there, get that feedback, make it very clear you are there to listen and learn. You're not doing a sales, and people will be very forthcoming with their information. And then I'll reinforce the buying question with a failure at GE. So I led a skunkworks project to try to bring diverse data across different modalities together to support what's called a tumor review board, also known as an interdisciplinary team. Worked on the technology, talked to clinicians, they were interested, demonstrated it at a conference, they were signing up. We decided to commercialize it. They brought on commercial people, and the next year we found out that there was no reimbursement for consultation unless it was greater than 30 minutes. And a tumor board could easily go through 10 people in 30 minutes. So we failed to understand the motivation and drivers of our customers. So for fee-for-service hospitals, there was no buyer, and we shut the program down. It still bothers me. So understand, you know, what's the motivation for customers to change, and make sure it's aligned with what you're offering. Otherwise, you're pushing a rope and there's no pull.
Sorry, my screen just went black. Computer issues. Okay, so next up, some of the questions that we were focusing on, still early stage, is, you know, in healthcare, understanding reimbursement, how your technology fits in, and also regulatory. I know, Ilka, you mentioned a little bit of this, but with healthcare, there's a lot more complication on safety and how do you get it into hospital system. Can you guys touch upon, you know, how do people start looking into this and finding some help for answering these questions?
Sure. I mean, in general, in healthcare, you want to differentiate. Are you offering a product that, say, a hospital or a health system or a clinic will purchase? That's one way of paying for it, you know, a capital investment, so to speak, or a disposable that people will keep replenishing. Or are you offering a service that will be reimbursed by health insurances? And that could be Medicare and Medicaid and any other commercial payers. And so if you're selling capital equipment, then, you know, like an X-ray machine, for example, then this would be funded by a hospital. And, you know, there you just have to make sure that you're competitive, but you're not really looking for insurance reimbursement. What you are concerned, though, is that the people who purchase your capital will be able to obtain insurance reimbursement for the services that they would provide using that equipment. And so, you know, a good place to start would be look for comparables. You know, so for example, I used X-ray as an example. If you're developing something that replaces an X-ray, or, you know, it's something similar to that, you want to look at what the reimbursement is for similar services that are in the market. And, you know, there are billing services that can help you also understand what the codes are. There are these procedure codes, CPT codes, that are used in order to determine reimbursement that Medicare will pay. And in healthcare, you know, more than 50% of all medical services are paid for by Medicare. So that's always your single biggest payer that you want to look into to start with. And all the Medicare information is public, so you can find that actually online. You just may need some guidance to determine what are you actually looking for, but you can download Medicare fee schedules and then get an idea as to what Medicare is paying. And then there are different rules of thumb in terms of what multiples of that other commercial payers may pay for that.
I'll jump in with more of a meta perspective. So I know when I came out of my second bout at school, I was very focused on helping cancer patients. And I thought, okay, anything that helps them, you know, they're the beneficiary, is going to be a win, because all too many of us have been touched by cancer. It motivates people. You know, I can, you know, work a room with a presentation and I can tell who's been touched by cancer directly or indirectly by when they lean forward and things like that. And that's too narrow a perspective, because in healthcare, I would say there's a triad. There's the beneficiary, the patient, there's the user, which is often a clinician, and there's a buyer, and that could be public or private insurance. And to think that just because it's of interest to one of them, the patient benefits, it's of interest to the others, will lead you astray, because sometimes there are disincentives, and that's what caused me to shut down Trailhead, is I didn't appreciate, you know, yes, it's useful to the patient, but you need to understand what the motivation are for the people that are using it. And of that trio, the patient has the least amount of information, least amount of leverage. So if you pursue them, you know, you're going to face a headwind. If you understand what, you know, drivers are, either they need to save money on their delivery of service, or it's a motivation to comply with JCO compliance, you know, requirements, or new Medicare or Medicaid drivers, whatever it may be. If you understand that and you can put your value proposition in that context, you'll be able to go a lot further.
I lost track a little bit of the question, but if I could, I have an anecdote that that came to mind. And I think if you're kind of dealing with hospitals or healthcare systems, that seems to be the theme. What came to mind after hearing Ilka and Scott is that especially if you have a service, I think that's more where I've worked, I don't necessarily work with a product, although I did with the pharmaceutical industry. But if you have a service you want to kind of pitch or you're interested in studying, one thing we learned at Concordia, for example, in the IPE world, we're trying to tell hospitals, oh, if you do team-based care, you're going to do better care. But the throwback on that always is like, how do you pay for that? And how do we distribute the money in a team-based setting? So we came up with some pilot ideas where I think if you can convince a hospital or a that you're going to improve outcomes, that's usually the language they like, or that you can reduce readmission rates. I think if you put your product or service in the context of saving these systems money, you know how to talk about that using the tools Ilka was talking about, and you have that knowledge, often they'll bite pilot projects. So we did a few student-driven, team-based in-home visit products for Ascension, for example, for people who had been hospitalized with heart issues, and they wanted to see if we could do a certain kind of intervention that would keep them out of the hospital for 30 days to ensure their reimbursement. And that was very sellable to the hospital. So if you have an idea like that, where it's a service, I think mapping it out with all the sort of numbers.
Understand what's going on.
Sorry, somebody just got unmuted. Go ahead.
That's my cue to stop there.
You know, in connecting with that also, I think the hospital is so unique, and from what I've heard and learned, like it's sometimes really hard to get a foot in the door. So, you know, having been on the inside, you know, that was one example you gave of kind of, can you pitch an early stage, you know, partnership or just a test trial with them? How else do you get in the door and figure out who to talk to?
I think the first question you have to ask is, you know, who cares, right? With what the product or service is that you have, who's benefiting from, you know, the concept that you have, the idea that you have, and can you find someone that is in that field that would develop a passion for that, you know, that you can have a conversation with and really get excited about it. And that may not be ultimately who makes the decision to purchase the product, but that could certainly be someone to get you into the door and can then help you to figure out who makes the decision. And so, you know, if you're making healthcare products, it's always good to try to understand which clinician or which, you know, profession would use that. You know, so if it fits into cancer care, who do you know that is in cancer care? And you may know someone, even just socially, who can get you started and introduce you. And, you know, a lot of people may know someone who was a patient of something, and, you know, start with that and just ask your way around.
Yeah, I'll build on that with a plug for the mom test. It's a book that's used in ICOR. It's a great book. And I don't know if it was literally in that book or just part of the surrounding conversation, but every time you talk to somebody, your final question should be, who else should I talk to? You know, so oftentimes they're not able to help you because, you know, they got budget constraints or whatever, but they're always eager to say, here's somebody else that will help you, you know, learn more, something like that. So that's a chain of, you know, connections to learn. And I'm also not going to sugarcoat it. Hospitals are getting to be a harder and harder market to sell in due to consolidation. You know, if it used to be, you know, based locally and you could talk to somebody in the leadership there or a department head, you know, they would often be open to saying, well, yeah, we'll help you explore this. But with consolidation, it's, well, it might need to be talking to a team that's, you know, 3 states away or 4 or 5 with a longer product cycle. So that favors the big established companies. There's no sugarcoating that. So look for the smaller opportunities, you know, the public clinics, you know, the ones that are, you know, scarce resources and would love to be a collaborator if they can try something that they think helps them locally. Look for VNAs that are locally owned or things like that. And then I'll also put in a plug, if you can, work with the VA, because I think the VA is unique in the US in that they, any intervention they have on behalf of their patients, the VA will benefit from because there's no disconnect at 65. And the behavior of healthcare providers and payers is skewed by the fact that, well, you know, we could intervene now, but they're only 60 and the benefit comes 6 years down the road. We won't benefit from that. That distorts things. The VA, on the other hand, and if you look at what they do, it reflects that they know an investment in the patient is an investment that will help them because they have them for life. So look for the unexpected cases. Don't go after the big hospitals from the start.
I see there's some chat. Good things going on in the chat. I just had one quick sell that really everyone here, if you can tap into academia, I think that's a shortcut like Ilka and Scott are talking about. The good thing about the mom test, that to me was like ethnography, and you need to find someone who knows the hospital or knows the system. So for example, if you reached out to any chair or dean at the School of Pharmacy, they would link you with pharmacy that a pharmacist who works in cardiac care at Aurora or in cancer care at Freighter. And these in academia, many of you know this, you're required to do research, teach, and service. And you're going to find someone who might be curious about what you're doing because they want to talk to you, they want to partner, they want to help you. They would look at it as professional service. But I think if you went to Marquette, their PA program, MCW with their physicians and how they work in the clinics, you can find someone in academia where you'll have a little synergy with your idea, and you just have to keep reaching out. But I would start with chairs and deans as kind of the initial filter. They actually answer their email.
Thank you. This is timely because I was just speaking to someone yesterday who said they weren't getting a response and was wondering if it's because they had a Gmail address. And I said, well, I'll do what I can. I know the tech transfer people at MCW, but, looking for clinicians there, they're busy. They don't always answer. So I appreciate that advice. I was like, I'm happy to help if I can pass it through who I know at MCW.
And maybe a couple additional ideas. There are networks here in the area that actually can be really, really helpful in pointing you in the right direction. The first person you talk to may not be the right person, as Scott was saying, but then you ask again, who else should I be talking to, or who can you put me in touch with? So BioForward, and I think I saw Mike Harrison on here, the Wisconsin Technology Council. So there's an entrepreneurs conference. If you attend one of those events, there are different events that are specifically geared at building networks and putting you in touch. There are the innovation lunches that the Tech Council puts on. There are different investment groups. There are angel investors. They're great to talk with. These are people that are investing their own personal money on innovations that they think are worthwhile. And, so there's some in the Milwaukee area also. We just heard Karen Plunkett and name escapes me right now, from a different investment group, talk about it. So there are lots of contacts where people would be very interested in talking to you and understanding your ideas, and could potentially point you in the direction of someone that in this community here, has other contacts that are really worthwhile talking to.
Great.
I just put a link out to healthtechmke.org. And that's the organization that Ilka was alluded to. My personal view of it is we want to serve as a catalyst, and oftentimes that's being a connector. We'll try to help things happen. But I think in general in Milwaukee, my experience is people are very willing to help, but people are sometimes reluctant to ask. And sometimes, the networks aren't as obvious. So not everybody is as well connected as, let's say, Brian, he makes a fine art of showing all the connections between all the different organizations. So get your toehold in. And then, like I said, always ask, who else should I talk to? And build your own network, and look for people that can help you.
Yeah, you got to go to the big events in our area if you want to network. And so the Tech Council has the Early Stage Symposium coming up November 3rd and 4th in Madison. And then they have the Entrepreneurs Conference, as she mentioned, in the summer. There's the Governor's Business Plan competition. So people are reading your proposals who are judges in the industry and getting to know you, and they'll keep hearing about your startup over and over if you continue to network at these events. So.
There's Wisconsin Innovation Awards. The presentation of the winners is in a couple of weeks in Madison. So that's open to all companies in Wisconsin. I was lucky enough to be a judge this year, and there's some exciting stuff coming through. So go there and network.
So moving along with some other questions we had previously had on hand, one topic on here that I don't believe we've covered yet is the area around telehealth. And, if anyone is involved in that, how is that important and changing right now, especially with the pandemic and so forth? If you guys have any advice on that space?
Yeah, there is a lot that has changed during the pandemic, and I'm sure most of us have, taken advantage of it at some point, starting with these virtual visits that you can do with most of your primary care physicians now. Every large health system is supporting it now, and it's very easy to, get access to a clinician through that. There are some things that I would say are lasting changes during the pandemic, now that we understand how easy it is to make this happen and reimbursement is in place for it. And it's a huge time savings that you don't have to travel somewhere, sit in a waiting room and do all that, but you can just schedule a brief time with somebody and do it from your phone. There are some areas where there is reimbursement now that has been put in place during the pandemic, and that is here to stay. There are also areas where temporarily, for the life of the pandemic, reimbursement has been put in place by CMS. And in the area that I mentioned earlier, addiction, recovery, pain management, behavioral health, there are a lot of things that have been done virtual, which have some limitations because the therapies that usually are done may require in-person visits or also group visits, and that's been compromised during this pandemic. And so some of those may not stay long-term, but a lot of innovation has happened in that area particularly. And there's a lot that can now be done virtual that we didn't have solutions for. So it's a great area for innovation, and reimbursement has greatly improved in that space.
If I could just make two quick comments on that. I love everything Ilka said. And again, not to keep repeating myself, but for example, we have a telehealth pathway now in our school of pharmacy. I'm sure MCW does, Madison. And you'd want to connect with some of those faculty working on that because they've worked out so many bugs over the last 3 years. They could really help you. And I think there's a couple of things going on in that marketplace that are interesting. So we have pharmacists actually doing telephone calls, not virtual calls, but telephone calls. And that's interesting in terms of reimbursement. They're working with Marshfield Clinic in terms of medical compliance, deprescribing, answering questions. But then what's really interesting to me is that the iPad kind of device, smartphone, has allowed clinicians to go to the home with patients. And that's kind of that patient-directed care where there's this emphasis on patients managing their care, but doing it through these virtual tools. And that's really sort of new and untapped in a lot of ways. And the kinds of platforms being used, that's a really interesting area. We've had some students work on that in Sheboygan County, where iPads were used to do like Zoom calls for diabetes management. And the patients really responded. The question again is, who's reimbursing that home call? Those are all these kind of more technical questions, but I think that space is, like Ilka was saying, my wife's a psychotherapist. She gets a call every month to join some national psychotherapy, teletherapy business to get part of this network of 20,000 therapists. So obviously there's all kinds of things going on in that marketplace that are exciting and worth exploring.
Yeah. The only thing I'll add is to point out what's easy for those of us who live in a large metro area. I'm 2 miles from Freighter, and I may not have been able to go in due to COVID, and that can and perhaps should change when COVID's less of a threat. But then you look at outlying regions, and that's a durable, persistent, underserved population. So for example, if you're a parent and have a child with cystic fibrosis, you're golden if you live in Milwaukee or Madison in Wisconsin. But if you're up in northern Wisconsin, you don't have access to the same specialized resources. And that's always going to be there. And that's a recognized problem. So you need to look and say, what are the current mechanisms they have in place? Can you provide higher quality service at equivalent pricing, so that you can say this isn't an increase in societal burden, but a decrease, and provide improved outcomes. That's going to be there for a long time. So get out of the building, get out of the Southeast Wisconsin region, and talk to people that are in underserved communities. And I should say, not just the patients, but the clinicians, because the mindset there will be different. Is sometimes they will say, sure, you can refer people to a specialist down in Milwaukee, but I need to be a generalist. I need to treat all of my patients, top to bottom. And they may have a certain amount of pride to be able to do that, even though they don't have the specialized knowledge to provide the highest quality care for narrow clinical needs.
Thank you. One of our teams is a bit further along, got a little bit of funding, and has the prototype and is looking now to get into the hospitals. And one of their questions was sales calls. How do you do it? And what's the timeline? I guess we kind of touched on that, but we were talking a little bit earlier more about partnering and maybe, testing things out. What about when you're ready? And you got to find the right person, like Ilka said, but any other tips on setting up these meetings and moving forward?
Well, one thing to consider is that you no longer can just walk into a hospital and try to sell something to somebody. So sales reps need to be registered on a system like RepTrack. There's a number of different systems that are used to register you as a formal sales rep, and most hospitals will not let you just wander the hallway to look for somebody, but you need to be registered and you need to make an appointment ahead of time. So that would be a good place to start. Then generally, if you're, through that step, and I guess you're looking to call on someone, you may want to start by just calling the department. Typically, you can find contact information online, and you can call an administrative assistant to see if, Dr. So-and-so accepts appointments, and, how you can go about that.
Yeah. So I'll go back to the mom test. If you've established a relationship where you're learning from them, where you currently are, in a student role, and you maintain that relationship, so that you have a credible understanding of the internals of the organization. When you go back in, whether it's your contact or somebody else that would be benefiting from what you're offering, they should be part of the conversation along with, let's say, the purchasing department. The purchasing may not feel the problem the same way. They may not prioritize the problem the same way. So if you have an insider, that can be the liaison that understands the value you add, but also understands how the organization operates. That's invaluable. And I will say, I'm going to beat up on GE for a moment. One of our customers said, "Oh, you're hippos. You come in with really small ears and really big mouths." That's not a good relationship. You should be listening more than you're talking. You should be learning more than you are teaching. And if that relationship is genuine, so you do come in and you really are credible, not just spouting buzzwords, that comes across. That's obvious. But have that partner inside to help you appreciate why things are the same or different than what you expected.
Can I give the 30-second academic plug, kind of building on both these comments? Look at UWM, Concordia, Marquette business schools and see who are doing healthcare administration, who's working in the healthcare sector within the business schools. So for example, we have a couple of professors that worked for Aurora for I think 10 or 15 years, and now they've got their PhDs and they're working on healthcare, MBA, healthcare administration tracks. They might be great contacts to help you get a foot in the door. I think that's a really great question, because having worked for the pharmaceutical industry for 10 years, the hospital was the toughest place to kind of cold call. I mean, it's you can't do it. It's in, as Ilka said, you can't really cold call now. You have to have some kind of conduit or pathway to decision makers. And I think often some of our business schools have that. And even within obviously a medical school or pharmacy school, they'll have contacts that they know.
There were some specific areas, Scott, that you had mentioned you could speak to. one of which was talking about medical device security. What can you share on that?
So what, 15, 20 years ago, I was leading the medical device security efforts for GE, working with the DoD, the FDA. And I wish I could say that they have made an incredible amount of progress and it's a well understood problem and that devices can be used reliably in a clinical setting, but that is not the case. If you are creating a device that needs to go into the hospital, you have to assume that it will have a life cycle of, let's say, 20 years. And that was certainly true when Ilk and I were working on CT and MRI scanners and stuff like that. But even smaller devices, you have to assume that it's got a long lead time or long life cycle, and you're going to have limited, if any, ability to update it. So you need to absolutely look at the attack vectors. You need to look at how you can lock it down and make it a minimal device, not a, it does everything device. So it does what it needs to. It's safe, it's effective, it's durable. And then you need to work with the healthcare IT departments that are going to want to start patching everything they find on their network, which can lead to adulteration of the medical device. So there is no magic there, but you need to anticipate those sorts of pressures and realize that if you're looking at a regulated device, there are real constraints that make things very, very difficult. That said, if you're credible and you've got a supportable product that anticipates all those needs, the IT and the security departments in the hospitals will be much more receptive to approving what you are offering.
Yeah, one thing to really be aware of is, and I'm sure everyone's heard about the cybersecurity issues that are going on. And in healthcare, it is a particular issue because you're working with patient confidential information. And so if your product idea contains any kind of patient information, you have a special set of requirements around that, and that you need to be HIPAA compliant, and any exchange or interface that you do with any other device in the hospital will be guided by very strict regulatory framework. And that's something to really inform yourself about early on.
And I think another area that I'm not familiar with, Scott, you mentioned was clinical interoperability. What is that?
It is the dirtiest set of data you will find in the world. Excuse me. So many people are familiar with EMRs, electronic medical records, or EHRs, electronic health records, and think that, oh, excuse me, I laughed at the wrong time and inhaled my hot chocolate. That is intended to provide clinical care. And the cynic's view, or the experienced practitioner's view, is a medical record is first and foremost an evidentiary document or a billing document. And people that have really done it for a while realize those are one and the same. So you look at all the information that's being collected about you when you visit your clinician. If it helps clinical care, that's secondary. The real thing is so that they can build, they can go back to the CPT codes that Elka mentioned earlier, and they can get reimbursement for the time they just spent with you. That said, there is a great desire to change that dynamic. And there are thousands of people worldwide that work on standards to exchange information within IT systems. That's often done through an organization called Health Level 7 that comes up with standards for how we can exchange structured clinical data. If you're looking at imaging data, that's going to be DICOM. So that's the standard that's there. And it's a bit of a challenge because we can come in with a great idea. This is how we can help a clinician using their genetic background, their family history, their predispositions, and all that sort of stuff. And if only we had that data, we could make a prognostication about what the appropriate care or intervention should be. But that data wasn't necessarily collected for that purpose. It wasn't necessarily stored for that purpose. It's not harmonized between different institutions. So what I would recommend if you want to tackle that space, you look at a company like Redox out of Madison or Moxie. Moxie is more on the payer side, also out of Madison. Redox will help a small startup that has an app that needs to integrate to a hospital. Let's say you want to get it at Freighter's medical records. So they will provide the glue code that will comply with the business associate agreements with the institution. It will have the appropriate reporting, the appropriate security constraints, and the appropriate disclosures about what sort of data you're going to get for picking out of thin air diabetic patients, because you've got an app that will help them. So don't try to break into the IT system yourself. Sorry, break in is the wrong term. Don't try to get into that market yourself. Look for a partner that can help with that interoperability, and then they can provide consistency. So whether you're going into an Epic system or a McKesson system or some other player, you could get a standardized set of data that you can feed into your algorithm that can influence care. So it's my LinkedIn connection is there. If you want to talk in detail about clinical interoperability, we need more than the 15 minutes we have left. Feel free to reach out.
And then another topic is what should these people be considering regarding healthcare policy? How does that play into the startup?
So Ilka quoted Medicare and Medicaid are what, half of the reimbursement in the US? Did I remember that right?
At least half of, once you consider all the other commercial plans that are HMOs and PPOs, you're actually much higher.
Yeah, so you need to understand what their priorities are. So once again, I'll go back to a hard-won lesson at GE, is we had a new offering. I actually don't remember specifically what it was. And this was after the industry had changed to where you needed clinical evidence, not just clinical practice, to make a commercial claim for your product. And we had done some clinical research, and we hadn't broken up the patient population with under 65 and over 65. So CMS said, this doesn't help us. We're not willing to act upon this information. Reevaluate or break down your cohorts so we can show the benefit for the core of our population, which is 65 and older for Medicare, and under 65. So that's an example of where high-level policy at a national level could influence your product offerings, and you need to understand that. And then the other part is more understand what the top level initiatives are. So once again, I think Ilka touched upon this, is if a patient is readmitted within 30 days for certain things like a central line infection, the hospital can't claim reimbursement for that because that's a failure on their part. So they've got quality programs to make sure that the checklists are followed, that we do sterilization before the central line is inserted to reduce the chance of reinfection. If you have something that will help with a national initiative like that to support it or make them better at it, then you've got a very receptive audience. If it's a problem that you think is important, but nobody else is worried about, and there's no national initiatives that are driving it, you still might be successful, but it's going to be a much harder road. And what I'd recommend is you don't abandon it and say, oh, I can't deal with this, is you look for an adjacency. You look for a place where there is that pressure, that external drivers, and be aligned with supporting that. Instead of saying, well, I can't fit the exact problem I wanted to go after.
The other piece I would add is standard of care. So in healthcare, it's really important to be aware of what the current standard of care is for a particular, episode of care or for a particular clinical, situation. And that is documented and findable, and physicians are expected to treat a patient according to standard of care. And so when you have an innovation that changes or intends to change what the standard of care is, you need to really think through how you gather enough, support for making such a change. And if you can accomplish that, of course, that would potentially be a breakthrough or a game changer. But the pathway to accomplishing that may find a lot of resistance because, the safe way to work with a patient is always be aligned with the standard of care. And so most likely you would need to work with academic health systems where you have someone who really, scientifically and clinically understands the benefit of the change that you're proposing or your idea, and who is willing to do some additional research that may not be immediately paid for. And academic institutions, of course, are interested in advancing the standard of care and finding new and better ways. And so you have to really think through what the better part is. Is it reducing cost? Is it improving outcomes? Is it reducing length of stay in a hospital, for example? Or is it improving access for patients to care? And if you can make a compelling argument, then people will listen and will be intrigued and will want to collaborate with you. You will need to gather enough evidence, that something that is statistically significant in order to get a society to want to change the standard of care. So that's a longer pathway, and it's, in general true that the more significant the changes that you're proposing, the longer it may take to get acceptance for that.
You kind of just answered the next question, which in a sense is, when you're ready and it's time and you do get that interview or that meeting to pitch your idea. I saw, Dave and okay, you guys were talking about what do hospitals care about. And one of the big things is that we all know is cost, will they save money? So you kind of just covered the things to focus on how to solve their problems, but anything else we're missing when you're going to pitch and try to convince the buyer or whomever it is at the hospital to take on your device, your technology?
I'll be very, very explicit because we've talked about it or alluded to it, is if you're going into a for-profit hospital where it's fee for service, it's all about volume and throughput. If you're going to an academic center, the mindset could be completely different, and that's within the US alone. If you have the resources to go after the international market where there's a single payer, the dynamics there will be different again. So do your homework, know how they're reimbursed, know what the pressures on the clinicians are, and then act accordingly.
We have a little over 5 minutes left. Does anyone else have any questions? They can feel free to unmute or type in any further questions. If not, I will say one thing I was curious about is a lot of people are mentioning iCore and getting customer interviews. And in the chat box, it was mentioned, you can get a lot of interviews by just talking to friends and family. But I'm just curious, friends and family can help you identify maybe some pain points, but when you're going to get these customer interviews, how should you mix it up in who you're talking to? Because the patient's not the one in the end that's going to get it to the market for you. I was curious how you guys conducted your iCore interviews, for instance, or any advice you have if people want to do customer discovery.
I would just say, don't be afraid to cut a wide swath. And we interviewed a lot of people. It was for sort of a sterile gloving idea we have. It took us to all different places, and we actually came up with, they made us take a giant step backwards in what we were, in a good way, in what we were developing. We kind of had it wrong, and we learned some really valuable stuff, but it was interviewing people kind of outside the box, where someone would say, well, I can get you set up with, say, a food service person, but then that food service person was like, well, I think you should interview this person. We took their advice and kind of followed almost like a snowball sampling, where the UE was telling us the next person to interview. And it was really helpful, because everyone here doesn't want to go down kind of a dead end path. You want to find the right path, but I would stay very open, and I would ask your informers or the people you're interviewing, they're really advice on who we should be interviewing. Do you have ideas come to mind? And that was very helpful.
Yeah, I would build on that. As you start with your personal experience, that's often the starting point, but you need to be willing to let go of that rather quickly. Kyle, who's a member of the company, is on, but I'll take the liberty of speaking nonetheless for Lindsay Roddy. When I saw her at the UWM Student Startup Challenge 5-6 years ago as a nurse, she had a cable organizer that she was trying to keep track of all of the cables, and she went through the different programs that we've alluded to and some others, and learned that it's not the cable management, it's a safety issue that was the real selling point. So what they're going to market now with is something that will prevent a cable from being, well, more importantly, pulled out. So it's secured to the arm, and that distance doesn't change, but if something happens downstream on the cables, it's a safety issue. So she took her starting point built on it and was receptive to the feedback that she was getting, and has come forward now with a product that I think is about to go gangbusters. Kyle, I hope you agree. Oh, he's got one right there. Yeah, so be willing to let go of what started you down the path, be receptive to what you hear, stay true to what your passion is and why you're getting into it. But the National I-Corps program says you start to learn what's going on after 60 interviews. Not 6, but 60. So
yeah, the only other thing I would add to that is don't be afraid to ask. I think we always have this thing where we don't want to look foolish, but don't let your pride get in the way. If you're passionate about something and you sincerely want to know something about it, don't be afraid to ask. And start with people that you know. And then, as Scott said, always ask, who else should I be talking to? And I was amazed how the snowball effect really worked while I went through the I-Corps program, that people were referring me and said, I don't know if this is really relevant, but I could introduce you. Would you be interested? Always say yes, because even if that individual, is someone where you thought they should be interested and they tell you they're not, that's valuable information as well.
Yeah, the who else can I talk to? I don't know that person. Can you take 2 minutes to make an introduction? Is the best advice we got from the I-Corps program to continue down that path to meet and open doors that you would never be able to cold calling.
And with a few minutes left and in the I-Corps fashion, are there any questions that I should be asking you today that I didn't ask or we didn't get to?
So Ilka has 3 questions. I actually have 2. So I heard this first in a clinical setting years ago, and the department head asked an intern, how will that change what you do? And I have found that such a useful question to talk to a startup. How will you change what they do? Who is you? Is it you as an individual, you as a consortium, whatever? Who's they? What are they doing? And then a lot of companies can talk about the change, but they can't say what customers do now. So that's the mechanics of what you're going to do. The companion question is, why will they change what they do? So what's the motivation they have to make a change? Because change is hard. And if you can get motivation, then you've got monetization for a startup. So how will you change what they do? And why will they change what they do? I love, if you can answer those as an elevator pitch, you've got a pretty good idea of where you're going.
Speaking of elevator pitches, actually, we're going to have a 2-minute pitch event. I believe it's going to be virtually coming up through our Licensing Executive Society. I have co-organizers with me from WARF and WISIS and others in town who are in the licensing realm. And so we're about to send out invites. So I hope I can get you guys on the list as well. If you're interested, we're gonna have 10 people who, first to sign up to do that 2-minute elevator pitch. And it's really just a practice for, fun and practice. And we'll have folks in the audience that can help provide feedback on what worked and what didn't work. So please do sign up or just come to listen and learn about some other startups. And so that will be in October, and need to get you the date, but I will circle back with all those that signed up today in case you're interested. And with that, I hope, Ilka, did you have anything else? It's 1 o'clock.
No, thank you for having us. This was very interesting. We always learn a lot from the other panelists too, so I appreciate it.
Thank you so much for taking your time today and providing your insights. It's been really helpful. I've recorded this as well, so I will send out the recording, or if you know of anyone, we'll put it on our YouTube page for the Research Foundation as well, and that way you can always access it. So thanks again, and I hope you have a good rest of the day.
Thank you.
Thank you all.
Bye.